let me start with kind of copying was what Dr. Webby said this morning about like how we explain to the people, you know, the patients, what a filum is if they have problems with tethered cord. I always tend to say it's kind of a leftover from your embryo times, and pretty much now we have it there. It's acting like an appendix. And as a provocative remark here is, when I said that last time to one young man who was in my clinic with his father, they looked at me and said, well, you know, if it's just a leftover and it's not good for anything, why then don't we all have it just removed before it gets us in trouble? And I said, well, you don't have to tell me. But anyways, that's for the start, okay? So you know, the way how I started to look at it is, you know, can we really identify? And Dr. Webby was mentioning all the symptoms and signs that we usually think we're observing in tethered cord, but can we identify a clinical syndrome that ultimately justifies surgical intervention and ultimately also predicts positive outcome for our patients? Because that's all that matters, right? And as we know, it seems like that the tethered cord problem can escape our imaging, and it's sometimes as subtle as, like, you can see here, like a smidgen fat in one of the MRIs that shows us, you know, that there might be something abnormal in a filum, but we don't always see that. So ultimately, it comes down to we have to trust the symptoms. We have to identify a symptomatology that leads us to offer surgery. So the way I kind of turned into a believer, and that's a little bit my story, sharing with you how I tend to approach it now, is asking the question, you know, is it true, is that syndrome really unique? So is it true that we always hear the same story from a patient that is suffering from tethered cord? And do we know of other syndromes that kind of help us to translate that we actually can believe in a syndrome, and how can we translate that into tethered cord syndrome, and then of course how to approach then the tethered cord syndrome. Let me guide you through this. So sadly we know from our children with spina bifida that retether later in their teenager age that they do have unique features. And I'm going to go over those a little bit, and took those and translated it to the tethered cord syndrome and how I look at patients with the symptoms and where I believe they have problems. And then, do we know of other syndromes? Yes, we do know that normal pressure hydrocephalus is also a syndrome where people have a specific problem, specific symptoms that guide us our way, but they have little radiographic evidence. The MRI or any other imaging is not really helping us to ultimately propose surgery to that patient. And I'll share that with you. And then how at Brown we propose the prospective evaluation of the symptoms to support the diagnosis in radiographic negative patients or with borderline findings. And we also looking at the histopathology of the filum, kind of as a biomarker, though biomarker usually is not something that you get after the fact. Usually, you know, you look at it before you make the decision, but maybe the filum, looking at the filum histologically can tell us, you know, why the filum had become nasty and is pulling at the tethered cord. Dr. Yamada has showed us what happened in the tethered cord. There's oxidative stress, as Dr. Webby was indicating, but yes, but ultimately it's provided by the filum. And so why is the filum acting up nasty? What's wrong in the structure of the filum? And then, of course, review our accuracy of the MRI, because the MRI is obviously not showing us what we need to see. So let me go over the tethered cord and spina bifida. So as I said, in the children now with myelomningocele that we can now diagnose in utero, when we do the closure when they were born, we know that we have to watch out for them showing signs of tethered cord. And these are, as I said, I hate to say the most obvious, like people to look at, because they, in the MRI later on, still have their cord tacked down to the area of the previous repair. So the cord is connected to that area through a big scar. So easy to believe that they are really, really tethered. And those kids, they do show quite unique findings. I hope that Dr. Webby agrees. They have those things that you went over, like more aches, burns, not really a sharp pain. Legs feel heavy, more stiff and tight, not dermatomal, not to a certain area. It goes from one leg to the other. And as Dr. Webby said, the pain is not like radiating, not really like shooting down in a certain, area of the legs. It travels, it's patchy, and often asymmetric. And this is something that I have seen, at least in the patient population that I oversee, that asymmetric findings are probably, if one leg starts first over the other, that is probably a very good predictor of tethered cord. And we shouldn't be surprised that findings are asymmetric, because with what Dr. Yamada taught us, that there's somewhere a stroke in the spinal cord happening because of oxidative stress, that could be random. The filum is not telling the tethered cord where to stroke out. So we're expecting, variation of findings, fluctuating symptoms, traveling symptoms. Okay, and then from infants to young adults, there are certain neurological signs. I want to draw the attention to the young adults where not only pain but also spasticity and hyperreflexia, probably from a more long-standing disease and from some damage in the cord that's been done, is an indicative sign. And I see that in a lot of adults as a good prognosticator, and I'll show you later. Urology is, we check those kids for more worsening in their bladder function, and usually that happens in the spina bifida clinic, for example. We don't accept more than 3 urinary tract infections per year, so that speaks to some retention and some problem here. And then, of course, the orthopedic realm is the foot and leg deformities, scoliosis, delayed growth or plateau in growth. So in spina bifida, we are already looking at like kind of a triad of neurological, urological, and orthopedic findings. And Dr. Webby actually had published that triad, and mainly in pediatric patients. So that's where we are coming from. So we have unique symptoms with a triad with some unique findings, and asymmetry probably is very important, but also progression. If it comes down to believe that someone is really in trouble, then often monitoring and seeing progression over 6 months or a year in those specific findings can guide you to make the decision of a surgical approach, and that's how we approach spina bifida children. So the answer is yes, the syndrome seems to be unique. So do we know of other syndromes? And this is kind of a home run for me, I have to say, because that's kind of where I'm coming from. I had worked on identifying or further providing evidence of normal pressure hydrocephalus treatment and diagnosis. And needless to say, Salomon Hakim, who's no longer with us, a great pioneer, he and others pioneered a triad of symptoms consisting of cognitive complaints, dementia, balance problems, ataxia, and urgency incontinence that to date, after decades of research, is still the main pillar and the mainstay of treating a patient surgically and predicting the outcome. And here the same thing a little bit. So of course, with normal pressure hydrocephalus, we are looking at like some swollen ventricles or enlarged ventricles, but that's not always the case. Some people only have marginally enlarged ventricles. Some people have a lot of brain atrophy, and at some years, people had shied away from treating those because they felt, oh, it's a sick brain, and often patients also have stroke around the ventricles, pretty much like subtle changes that we also kind of assume are going on in the spinal cord with the chronic tethering. And no imaging really is yet to date is guiding our decision. It is and probably always will be the triad of dementia, ataxia, and incontinence. And when we did the guidelines with our fearless leader, Tony Marmaru, we were thinking, okay, then the syndrome has to be looked at its certainty to help us to see who the patient is that would most likely benefit from treatment of the hydrocephalus, which is placement of the ventricular shunt, as you know. So we looked at supportive clinical findings and did some evidentiary work, meaning like scrolling through the literature, picking what's out there and what is uniquely described. And so we found some symptoms. That's hazy, but I don't want to go over that. That there are some symptoms, if they are there, they really make the diagnosis probable, so very likely. Some symptoms, you know, are not as certain to support the diagnosis and surgical success. So these are categorized as possible, and then certainly symptoms like headaches and normal pressure hydrocephalus are not really like what we find and not unique, so they should make us shy away from treating a patient. So that is certainly systematically how you can approach a syndrome, and I think we can also do that in tethered cord. In both pediatric and adults. So that said, you know, okay, normal pressure hydrocephalus, you know, we could use the systematic approach that the group has shown here and just translate that into tethered cord. And this is more a suggestion to the physicians, but also to all of us to think about it. I mean, certainly we learn from normal pressure hydrocephalus, you can trust a triad. So, and then we learn from normal pressure hydrocephalus that sometimes the pathology escapes imaging. I just told you the MRI sometimes doesn't really show us what's going on in the brain. So biopsies had been done in normal pressure hydrocephalus, and they had shown what's really going on in the brain. For example, just some examples here. Hope you can see it. That is a vessel, and there are brown spots around the vessels. That are amyloid plaques. You know that as our brain ages, it's leaking, you know, amyloid, which is a degradation product from dying neurons, and those accumulate around the vessels. They break them down and the brain starts to leak, and that's probably why the ventricles swell. And also a lot of inflammation going on as a matter of the amyloid accumulation. So it's an inflamed, leaking brain. So okay, that's why you know, progress with your symptoms, and the MRI is not showing that, of course, not yet. So that gets me to the next point, that we have to also look at advanced imaging. Dr. Webby was saying, and I want to copy on that, is that certainly people tend to put people prone in the MRI scanner in order to really, you know, see, is it that then the conus is not falling forward. But my discussion point is, we have to consider the cerebrospinal fluid movement still, right? I mean, our spinal fluid moves with the heart rate, moves with the respiratory thing. That is both in prone and supine position. So as long as the MRI cannot X that out, I wonder, you know, whether we ever are going to be good with mimicking, you know, or seeing what's happening in there. So advanced imaging has to maybe better allude to the disturbed CSF dynamics, and that's just an example in normal pressure hydrocephalus, where you sometimes, you might not see it, but sometimes you can see like webs in the aqueduct that, or functional webbing of the aqueduct, obstruction of the aqueduct, that speaks to some blockage in the fluid circulation, and then some surgeons tend to do endoscopy in normal pressure hydrocephalus. So advanced studies that are better CSF dynamic biomarkers might help us there. That gets me to the proposal to approach the tethered cord syndrome, and I want to share some very preliminary result of our kind of retrospective / prospective review of 58 patients with.
We need to.
Oh, okay. Are we? Okay, good. Yeah. I'm sorry.
You're going German on us.
Okay, good. I thought 30 minutes. Am I already on 30 minutes?
Yeah, a little bit.
Yeah. Okay. So. I apologize. So we are looking at the qualifiers, the criteria, and certainly if there's progression of symptoms, we offer tethered cord release. And these are the patients. We have pediatric and adults. And so far the results show that we can predict abnormal intraoperative findings in about 80% of patients, and all filum histologically looked at have some abnormality. We do know how a normal filum looked like we have some evidence it's collagenous fiber, but fat or ventricular cells, inflammatory changes should possibly not be in there. So when we look at the histology, we also find on top of fibrous and adipose tissue, vascular lacunes, breakdown of elastin fibers, mast cells, inflammatory cells, but also EM studies show abnormal collagen, kind of like corkscrewing or disintegration of collagen, and that's probably the culprit. Collagen breaks down, and certainly that leads to the suspicion that connective tissue disorders are linked to tethered cord syndrome. I'm going to go to the last slide in order to protect the time. We look at clinical and functional findings in the realm of urinary, and then symptoms and signs, and then also look at pre and post. And you real quick, you can see here that certainly leg pain, there are some symptoms that are more unique than others, more frequent in patients, and those that are more prevalent are dropping down significantly 3 months and also 1 year after surgery. This should just kind of give an idea that there are more frequent signs amongst all that we look at, and those are also the ones that go down, and probably those are the predictors of good outcome. Same for bowel and urinary, and we are looking at significance here also in our table. I was not going to get over that table anyways, but just so you see that urinary leaking, lower leg pain, and also hyperreflexia, clonus are signs that significantly improved after surgery. I'm done, almost done. We have probably signs that are predictive, like fatigue and weakness, paresthesias, cramps, abnormal reflexes, clonus, urinary retention and leaking, and back pain, kyphosis, and the turning of the feet that Dr. Webby was mentioning seem to be predictor here, and the asymmetry of findings. That is the approach that we have to look at borderline findings, probably in those patients, and those that were determined occult in our patient population. When we review the MRI, we sometimes can see a smidgen of fat or maybe a borderline low-lying conus, so also that has to be looked at. So there shouldn't be the myth of the low-lying conus anymore. We should accept that the tethered cord syndrome is a syndrome that we have to look at without radiographic evidence, and so we have to understand more what is wrong with the filum in the spectrum of conus and filum pathology, and tethering is not defined by conus position, probably more by contents of the filum, which need to be studied. That was Dr. Yamada's word to us. You know, we are having this dichotomy that we cannot rely on MRI data because we would over or underdiagnose patients. And we have to accept, and maybe we can agree in this, that the filum pathology escapes the imaging. Because as a young girl, had nothing on the MRI, not even borderline findings, with a very thick, fatty filum, which you would assume you should have detected on the pre-op MRI. And I thank you for patience with me and for letting me give my talk. Appreciate it.